Let us just see some case examples and understand what needs to be done. This was a 59-year-old gentleman. It was 6 months since his index surgery done elsewhere. He had presented asking for an opinion. Obviously, his complaints were not much. Some pain at the fracture site, all right, but main complaint was some limb-length discrepancy, because we can see that the proximal fragment is in varus. There is some overlapping of the distal fragment, and hence it is obvious that he's lost or out on some length, right? So, like expected, this is fixed in varus, and there's absolutely no signs of progress of healing at 6 months. So, I'm pretty sure all of you would agree that this requires some sort of intervention, and that was what was suggested to this patient, that it requires intervention, and the intervention at this stage would be a full-on, that the implant has to be exchanged, because this implant is holding on to proximal femur in a mal-angulated position, and as long as this implant is in place, the correction of the angulation is very, very difficult. So this implant has to come out. We need to correct the alignment and fix it, and it has to be re-implanted. And obviously, the patient, not having so much symptoms, refuses surgery, and he comes back at 2 months now with a bigger challenge, that all those issues that we already had are there, plus he has a broken nail, right? And like I told, always a broken implant is a nightmare, because you never know whether you'll be able to extract this or not. Okay. If it is a united fracture, then it shouldn't have mattered. But if it's a non-union, and in these scenarios where you have to get this nail out, the broken part also, because as long as that is in place, correcting alignment is difficult, like I told. And hence, you need to be prepared for all the challenges. So the typical deformities that we spoke of, that the proximal fragment is abducted, externally rotated. We are seeing that nearly the entire flare of the lesser trochanter, and on lateral view, it is flexed, right? So these are the issues. Of course, broken implant is an issue, and then the entry point is wrong. The entry point is way too lateral, and on the lateral view, way too anterior. If you see this, the entry is nearly kissing the anterior cortex and then going towards the posterior cortex, thereby causing the flexion of the proximal fragment. So all these are challenges that one needs to overcome, and one needs to change to get a better result. Okay. So this was what was done. As we can see, the implant is removed. Fresh entry is taken more medial so that it's in line with the canal, and it is implanted with the cephalomedullary nail. Then a plate, augmentation plate is used, and the non-union site is grafted. Okay. So a nail with a plate with an augmentation graft. Okay. A nail with an augmentation plate and a graft. This is considered the standard of care now as we talk for most of the fractures, but especially true in a subtrochanteric fracture, because this takes care of mechanics, this takes care of biology, this takes care of the alignment. All those issues are taken care of, and hence you are giving the best possible environment for the bone to heal. Okay. Now, this is his immediate post-op. This is at 2 years follow-up, and as we can see, it's looks to be well united. Okay. This patient had an issue with this plate being proud at the trochanteric region. We all know there is a trochanteric bursa, and most probably it was causing some issues with the bursa. He had some bursitis and was complaining of pain, and was insisting on getting all the implant removed. That patient does not want a nail, because whenever the patients have some pain or some issue with the limb in which the implant is there, obviously the patient is going to attribute all the problems to the implant which is there in the body, and they want to get it removed, right? So the suggestion given from our end was that we'll only remove the plate, because whatever issue has to happen because of this plate, if at all. The nail is well within the canal, doing no problem whatsoever, holding its ground. So we'll not get that removed, because medially, if we see, it is not well consolidated, right? So this fracture might have been united, but this gap was always there. If you can see, even in the immediate post of the gap was there, although it was packed with graft, but we don't see much consolidation there, and hence it is riskier to get this implant removed. And like expected, what does patient do? This patient visits another surgeon and gets all the implant removed, because ultimately they are their own boss. If they wanted to get it removed, there is no dearth of orthopedic surgeons who are ready to, willing to remove this. So this was, the patient underwent a nail and plate removal, and lo and behold, at 2 months post the implant removal, he once again had a so-called trivial injury, but we all know it that the injury is secondary to the fracture, and the fracture has not caused the the fall has not caused the fracture, but the fracture has caused the fall. In the sense, his bone might have broken, and obviously, whatever step he was taking is going to triple and fall. because the bone is no more continuous. And he has now broken exactly at the same part. So this is what also happens, that whenever you have a non-union scenario, the bone might not be exactly back to its normal configuration. Now, mind you, that's why that Cox publication makes so much sense, that amongst all the regions in the femur, the subtrochanteric region is the one which has the maximal forces going through that, right? And hence, we cannot take any substandard union as a complete union. So what do we do? Again, do the same principle of putting in a nail with the plate and adding on some grafts. But this time we were a little wiser not to put the distal femur plate on the opposite side, because we wanted to keep the trochanteric area free. We just use a simple LCP and put in 2 screws on both ends of the plate, thereby thereby giving it an augmentation situation. Okay, and this is 3 months. This is at 9 months. This is at 2 years post the second, rather the third surgery, and we can see that things seem to be united. Whether we'll remove the implant, the answer is absolutely not. He's asymptomatic. We're not going to touch this patient, right? So this is a good example of how things can go horribly wrong in a subtrochanteric fracture. This is a case number 2. This is a 64-year-old gentleman, and we can see that this is an obvious cause of non-union. This is 8 months since index surgery, and trust me, I was not able to get his X-ray, his initial post-operative X-ray now, but this was exactly how it was put in, that the screw was not in the head at all. Okay, there was an oblique X-ray taken, something like this, in the immediate post-operative X-ray. Only one view was taken, and it was presumed that this is within the head. Okay. So it is not that this screw was put in and it has cut out, because if this is a cutout, you will always be able to see the track in which it has cut out. So it's always put in there. Obviously, even otherwise, that surface implant is not going to be a great implant for a subtrochanteric fracture. Then this is an obvious non-union. We may think it's malunion, but this is an obvious non-union there. Wrong choice of implant, wrong way it has been implanted, and this fracture had no chance of healing, because the screw is holding nothing. There's only one screw which is at the fracture. All these are distal to the fracture. So the entire proximal fragment is significantly unstable. So what was done? A very similar process to previous case, where entire thing was removed, get a good entry of a middle entry and a nail. And this is a distal femur plate of the opposite side being used as an augmentation plate, and put in screws on both sides, right? And of course, filled with bone graft. So this is the immediate post-op. This is at 3 months, 12 months, and we can see a good consolidation of the entire area, both in AP as well as in the lateral view. Okay, 2 years and 3 years follow-up. Again, this patient was complaining of some certain irritation of nearest trochanteric region, and only the nail was removed, right? The nail was removed at 2 years. I mean, sorry, only the plate was removed. The plate was removed at 2 years. And this is 1 year follow-up after the plate was removed, and we see it still in place. So, like I told, if you are putting a nail with the plate and the patient has certain issues, mechanical issues, then we could plan to only remove the surface implant, retaining the intramedullary implant. Okay, do not, or we can do it staged. We remove the plate in the first sitting, and after a certain time, say maybe 3 to 6 months, we can plan to remove the second thing, because as long as the plate is in place, we will not be able to really see one of the cortices. It may be the anterior cortex or posterior cortex, depending on where the plate is. So our assessment of union becomes incomplete. Whereas once we remove the plate, you can really see all the cortices and know whether there is a good solid bridging callus and consolidation between the proximal and the distal ends, right? That's the range of movement. As we can see, nearly the entire length of the femur, the thigh has been incised. So that's what we are talking of, that all this needs to be planned, and we need to be ready for these extensive surgery, which may have other complications like significant bleeding and all those things, right? So this is patient number 3, 7 months since index surgery. She is only 27-year-old, and she was asked to be complete bed rest for 6 months. Now that's the amazing part. Again, mind you, things are significantly changed now with the quality of implants that we have now. If you're doing a surgery, these patients need to be the whole idea of surgery is that we are able to mobilize these patients immediately post surgery, right? There's no way in the world we can not do optimal surgery and expect the bone to heal just by restricting the mobilization and restricting the patient to bed. Okay, that's a definite very negative approach that we need to take. So this surgeon, for whatever reasons, was not able to do a good implantation, right? So these screws, distal screws, were actually removed as a part of dynamization, and we see that it's fixed in varus, and uh, it's not united. Now this is 7 months since index surgery. What are our issues? Issues are we need to change the entry point because this is way too lateral, and there are too many cerclages. So now we don't know whether this entire segment is still having good blood supply or not. Okay, so we presume it's good, but we are not very sure regarding that. What was done? Again, a very similar procedure of a nail with a plate with some grafts. We are seeing different types of nailing and plating, only with the sense that this was done in different times. This was done way back in 2012, if I'm not wrong, somewhere during that time, and hence we are seeing the previous generation of a nail and a standard plate LCP. Okay, but overall the principles remains the same, that you correct the entry point, take a medial entry so that the varus is corrected, put in a nail, put in augmentation plate, and add in graft. So this is successive follow-up exercise of the same patient, and this is complete union, and we can see the complete range of movements, and again the scar which is nearly the entire thigh of this young lady, right? But correcting the limb length discrepancy also, that the patient gets back achieves the length that was lost due to the non-union or the mal reductions. This is the final follow-up of the same patient, and no problem whatsoever.